I appreciate y'all logging in. As I mentioned, I'm Dr. Peter Ramsey, president of OrthoSC, joint replacement specialist, meaning hip and knee replacement. I've been practicing here in the Grand Strand area for a little over 11 years now. So I'm getting to be one of the old guys. Recently went out west, and if I know any of you, grew a little gray beard. It came in a little more gray than last time, I think. But that's how this job goes and this life goes. That being said, we're going to talk about better outcomes, how we're achieving better outcomes in joint replacement. And I think to talk about what better outcomes mean, we have to talk about what we're used to and how we got there. And then we're going to talk about the technology standpoint of what I think may be some of the bigger changes that we've seen in joint replacement recently. So it's important to know joint replacement, whether they're talking about knees, hips, shoulders, or other joints in your body, is really and always has been a quality of life operation. It's been something where I think the public at large thinks that our job is to replace a joint. Our job is to fix or cure arthritis. And at the end of the day, that's not my job. My job is to help you get back on your feet. Or if it's a shoulder, Dr. Tupis or Dr. Chambers or one of our other doctors, Dr. Evans, and I'll miss some people here, but to help them get you better use of the arm. And at the end of the day, this is all about function. So I had a patient today that's got really bad arthritis, and she said, "It doesn't hurt me." I said, "Well, live with it." And she looked at me incredulously like, "I need a joint replacement." At the end of the day, I said, "Well, what am I going to make better for you? I'm going to make your x-ray look better. But other than that, we don't need to go through an operation for that. I want to know when it hurts you, when it affects your quality of life, and that's the time to do it." So when we're talking about outcomes, we're talking about quality of life. We're talking about in the long term. And then in the short term, how can we make that a smoother process? Because if you've talked to anybody that's ever had a knee replacement, I think you're probably aware that particularly knees and shoulders, more than hips for sure, these are some operations that'll put you back a little bit, particularly for the first couple of weeks. So how can we make the process easier? Well, a little history lesson, and these are really general numbers, but if you look back in the 60s and 70s, joint replacement, particularly hip replacement, started with a guy named John Charnley, who developed a hip replacement in England. And it was so important that they actually knighted him. So he's now known as Sir John Charnley, but he came up with the first hip replacement and some basic techniques to do that. And his results actually stack up pretty favorably to even things that we do now, but it was quite an arduous process to put one in. And it took a while to kind of get that technology and those techniques out to the masses. And so the next decade or two is really refinement of the techniques, the instrumentation, standardization of implants and instruments, so that at first it was basically a small, medium, large, and a knee. And you just made it work. You got in there and you kind of shaved the bone the way you saw it fit and tried to align it the best without any real instruments. And so over the 80s particularly, instruments were developed that let any old surgeon, if you will, kind of learn how to do it with standardized instruments and obtain the right angles and dimensions and really fit the instruments and the implants to the patient. Then the implant banks started to grow, the materials got better, things got more standardized. There were probably about 6 to 10 companies that made these, and nowadays we're down to about 4 because they all merged. But it was really a standardization time, a kind of learning time, distributing knowledge about how to do this and how to get results. And these are mostly on people in their 70s, because 80s was too old and 60s and 50s for sure were too young. But as we got to the 90s and 2000s, we started making progress, not just in this technology and how to do it process, but also how do we make it easier for the patient and get better long-term results. So in the 2000s, when I was in my training, I think it was 2003 to 2008, was my residency. I really watched us go, not just learning how to do some more minimally invasive surgery, but really take the process of a fast recovery and change it. So in the 60s, but particularly in the 80s, you're admitted to the hospital before surgery, you stayed in the hospital for 6 weeks, went to rehab for another 6 weeks, and finally after 12 weeks, we let you put your foot on the ground. By the time I was in training, obviously it was much more advanced than that, but we still had a 5 to 7 day hospital stay. You had a pain pump that you hit and got a bunch of morphine. And if you hit it too much, you got nauseous or fell asleep and lied in bed for a day or two before we even got you up, and couldn't lift the leg right off the bat. And by the end of my residency, we were adopting these things called multimodal pain management. So I put that in 2010s, but we're kind of a little bit on the forefront in the mid 2000s to get that going. And that was all about getting patients moving faster. And so we went from general anesthesia to spinal anesthetics. And it was led by this guy named Larry Dorr out in California, who's now all awarded and retired and everything else. But he really led that movement. And that's about layering Tylenol, aspirin, Celebrex, bunches of different medications at lower doses to try to get better results with less sedation and problems. And so we eventually got rid of those pain pumps and got people moving faster. And we watched the length of stay go from the beginning of my residency 5 to 7 days and the end of my residency 2 to 3 days. And so by the time I finished my fellowship a year after that and came down here, and no discredit to anybody doing joint replacements before then, but it was still a slower process here. So it was the first joint replacement fellowship trained doctor in the area. I was able to bring, it wasn't anything I developed, it was what I brought with me from the guys who were at the forefront, this more active, fast physical therapy, get out of bed same day, get home in a couple days, 2 to 3 days type approach, and really get you moving. So at the same time that we're toying around with minimally invasive techniques, which by and large, particularly with knees, haven't seemed to make that much of a difference in terms of recovery, less so in the hips, it's actually done better. But as we're toying around with techniques still, it was the medications and the physical therapy that really was driving the difference in terms of patient recovery. You get into 2010s and to now, and we've had computer assisted surgery and patient specific instrumentation, and now we're into robotic surgery, and those things are all, that's still on the technology side. And what that's been able to do is certainly drive how accurate we put in the implants in terms of our angles, dialing them into the degree or the half degree instead of the 2 to 3 degrees. But what we found is that 1 or 2 degree difference doesn't matter clinically. And so surgeons who do lots of these, more than 50 a year, it's really those of us that do hundreds, the robotics, the computer assisted has yet to make a clinical difference. It's narrowed the curve of errors of the surgeons who don't do a lot of them because they don't do them enough that they kind of miss their marks maybe more. But clinically, robotics and computer assisted surgery hasn't done a whole lot for the patient. So if we're talking about true outcomes, there's not a lot of evidence that says that robotics, computer make any difference. I certainly feel like that's the way it's going, and maybe the part of that's marketing, maybe eventually we'll get there in terms of outcomes. But right now, technology doesn't seem to be doing the robotics on that end of things. It's really been more about the pain management, rehab, and those types of things. And what that's done is taken us from 5 to 7 days to 2 to 3 days to 1 to 2 days. And more than that, it's taken patients from a discharge from the hospital to rehab to 1 to home. And so over the last 10 years at Conway, where I've practiced, we've driven the length of stay down to 1 point something days on average, all patients, all hips and knees. And then whether it's partly just because the next step of the evolution and or insurance and or patient preference and demand, we've done more and more patients as outpatients, meaning same day. Now, Medicare, to be clear, defines outpatient as anything less than 2 nights, but really what we're talking about in terms of outpatient, in my mind, is home the same day. And more than just home the same day from the hospital, now home the same day from surgery center. So for the past 3.5 years, I guess we probably started in 2018, 19, 20, or maybe it was 2017. I don't know when it was. 2017, 2018, we started doing hips and knees in the surgery center and sending them home same day. So now it's gone from 6 weeks to 5 to 7 days, to 2 to 3 days, to 1 to 2 days, and now it's down to 6 hours. As soon as the blocks wore off, we know you can get up and walk, and we try to get the appropriate patients home, and it's a growing number. I estimate that if insurance would allow me to do it, some are restrictive still, I'm probably doing 75 to 80% of my joints in a surgery center right now. And so that's moving very quickly. And I'll tell you, this whole coronavirus thing has only sharpened that focus because patients finally understand what we've been trying to say. Although hospitals are great places for taking care of sick patients, you're not sick. If you don't need to be around a sick person, don't be around a sick person. And so with the appropriate patients, and some are not, but with the appropriate patients, we're doing more and more in the surgery center. So what has that done? Well, it's taken a relationship that builds in our office, however many visits before surgery, to a short interaction right before surgery in the hospital or a surgery center now. And we used to have a daily rounds or even more than one day where either I would see you and or a PA would see you. So sometimes you're getting multiple visits in a day for several days, and there's this close contact. Now that we get people home, what are we doing with that? The day after surgery, 2 days after surgery, you normally could ask a nurse who's visiting, every however much, you hit a button and they walk in the room, and now you're home. and how many phone calls can you make, and how close an eye can we keep on you. And I think the natural evolution now is, how do we get to a spot where I can achieve a better outcome for you, make sure that our communication is still there. And that's what this talk is kind of getting into, is we're still very much our patient-centered care, but we have to make sure that we establish or reestablish or maintain a good level of communication, even when you're not here. And really what this done is started to make if you look at something like an ACL reconstruction, on average, those patients are younger, but that operation by scope and scale isn't that much different than a knee or a hip replacement, medically speaking, in my mind. And we've been doing that outpatient for a long time. So how can we keep these outcomes good? And that's what we're really talking about. So let's focus on this. It's a quality of life operation. And our mission at OrthoSC is to improve and restore the lives of the patients and communities that we serve. I very frequently even remind my own patients, the reason you're here today isn't for me to fix your knee. It's for me to get your independence back. It's for me to maintain your independence before this gets too long and you got to hang it up. So we're not focused on doing a knee, a hip, a shoulder. It's about regaining your function. And so think about where we've been, as a practice in this area. In 2000, we started, I'd say probably 7 or 8 years ago, talking between these three groups: Carolina Orthopedics and Merle's Inlet Coastal Orthopedics here in Conway, and Strand Orthopedics at the beach. And we've all been good friends, got along, very collegial, and a lot of professional and personal respect. So for years, we talked about potentially getting together, and for various reasons, some of them business, some of them convenience, cost, and all kinds of things, we thought this would be best. We want to maintain our independence as physicians, to maintain that close relationship with patients. So many physicians these days are, and this is my own bias here, but employed by hospitals, which has to influence your decision-making. I have no disrespect, and some of my best friends and best physicians I know are employed by hospitals, but the ability to establish that bond with a patient and make the patient-physician relationship central is something that we will not give up. And so in order to maintain our independence, it made sense to get our three groups together. So we've been merged now for a little over 2 years, almost to the day, well, an extra month or so there, a little over 2 years, so that we could continue to practice our way, which is responsible to the patient and no one else. I don't have to worry about an administrator telling me that I'm doing something right or wrong. I have to sign a form. We have to do what we have to do for insurance, and there are still rules, but we get to really design care for the patients. And the best way I know to stay busy is to have happy patients. It's not to sign the right forms for the hospital or ask them to put up a billboard or something like that. This is all about the patient. And so what have we been able to achieve as three practices in this area? And what do we bring when we come together? Well, this legacy of innovation. I was the first fellowship trained joint replacement surgeon in the area. Now there are several of us, and there's plenty of us that are not fellowship trained, but still excellent at joint replacements. At Conway, we developed the first comprehensive joint replacement program, and that model has been expanded to the other hospitals in the area. We were the first to offer minimally invasive total joint in the region, and to perform the direct anterior hip replacement, which I've now been doing for probably 8-9 years, I think. We do the most direct anterior hips performed in South Carolina, at least as far as I know. You kind of get a lay of the land and the surgeons in the area, talking to the device representatives and things. So I'll hold my feet to the fire, but if there's anybody doing more in the state, I'd be quite surprised. We now have a couple of us that even instruct other surgeons. So I'll go to another location and do a lab, or sometimes have them visit here and they can scrub in or at least observe the surgery that we do. We're the first to offer joint replacement as outpatient surgery, and the only surgeons currently, and for the foreseeable future, offering it in a surgery center. So again, from whether it's safety, quality, convenience, or what's becoming increasingly important is cost, surgery centers seem to be the way of the future here. So again, this is not on outcomes, but kind of a little shot to say our responsibility is to the patient, and it always will be. So we bring the specialized training of fellowships, expertise, and experience as a group and individually. And I think for us, the main thing is providing the patient experience and offering the good service. And some of that's fluffy, but a lot of it's not. And if you talk about a joint replacement and feeling comfortable with your surgeon, comfortable with the surgical team, and follow up and know that you're going to have your questions answered. And if there's any issue whatsoever, we've got your back, and that's what we want to be able to provide. So when we talk about this, the same day joint replacement is a culmination of years, if not decades, of innovations and processes. And to be able to pull off a joint replacement and send somebody home the next day, it has an incredible amount of moving parts to do that. You know, we have a lot of people that are centered around the patient. This is an old slide I actually took from an old talk I gave. And it's funny because I looked at this and I laughed, because no longer do we really have a quality department other than physicians that, you know, talk regularly amongst themselves. We don't really need a case manager per se, but what that's become is our nurse and MA staff. So really you have a surgeon, nurse, and assistant staff, or anesthesiologist, and then the therapist. And in HIPS, for at least me and most of us now, we don't even do post-op therapy. So we have a therapist come in, walk you as soon as your legs are woken up, and give you some instructions. And the goal for this education pre-op and post-op is that hopefully you don't even need much of it. And there's increasing evidence that with knees, you don't even need therapy to have a great outcome. I think there's a big step to get there, but bottom line is there's a whole team of people centered around the patient trying to get you what you need. And we've developed this over a decade or so here, and refined it, I should say, over a decade to offer what's a good and smooth process here in the hospital. We are in this spot now that we got through the first bumps of the road, you know, business-wise and otherwise, with the merger, that we're able to tackle some of these projects and combine the knowledge and experience of, I think we have 29 physicians now, if I'm not mistaken, and a bunch of PAs. And we're able to take evidence-based medicine and apply that, and take our process and really look at them. And so what we've had multiple meetings between everybody that does joint replacement, say, okay, what do you do? What do you do? Here's our process. Here's our materials. Let's take the best of all this and provide and create a great process for our patients. And so we've taken those three practices and we've built that, and now we have the clinical package built for OrthoSC, and we can apply it not just to the 4 hospitals in the area that we do joint replacements at, but now at the surgery centers where we have control as well. It's nice to be in a cooperative hospital, and many of them in this area are quite good at working with us, and we've been satisfied, and it's great. But there's nothing like being able to pull the levers yourself. And when I have a patient, I can bring them to the surgery center and know that I'm going to send them home in 6 hours. And what I say goes, more or less, or what we say as physicians and nurses, having dealt with patient after patient for decades, that we can make changes on the fly quickly. We can do things appropriately and lower cost, and arguably in a safer environment. It gives us a lot of power to be able to do that. So again, we go back to the same day concept, and we had this big group of people, and now it's a smaller group of people. And at the end of the day, when we send you home within hours, you need to know that we've got your back, and we need to have this feedback. And as much as I'd love to say every phone call is returned right away, I don't think that happens in every medical practice. And while we do our best and we have excellent staff, and we're always discussing how well we can do on that and how we can improve, you don't even want a single patient to be out there feeling like he or she has not, you know, had their questions answered. And so how do we tighten that bond between the patient, the surgeon, or really what I should say is a surgical team, because, you know, I do a lot, but man, if I didn't have the people working with me, there's no way we could pull this off. You know, they come to me and they know the answers most of the time, but they come to me for verification, or I give direction and they make it happen. So I need to give them a thanks. But how do we tighten that bond? And there's now a number of different technologies, and we've landed on one called CareSense. It's a technology that allows us to bond closer with the patients, both preoperative and postoperative, to make sure that the communication is better and easier. And I'll talk a little bit about what this CareSense looks like. So for me, achieving outcomes, you know, we've got to a spot where technologically we're almost bottoming out. We're spending money as a medical system on robotics and computer-assisted surgery that isn't necessarily driving better outcomes. But the money well spent may very well be in a technology that's more about the care aspect and providing a more seamless process between the patient and the surgeon. So CareSense is a product I'm going to talk about. What we've done with this, CareSense is an app, it's a website, it's a phone call and an email type platform. So whatever works for you. I know some people are really into things and others are not, but even for those that aren't into computers or apps or phones or anything like that, there's a phone call that they'll actually make for these follow-ups as well. So what we've done is we've taken our 3 practices. As I mentioned, we've melded the processes into one cohesive, and we've spent the time to break that down into information bits for patients. And you can see here, if the day of surgery is the vertical line you see, then that's the operation itself. And so what we've broken it down is into information bits. So you have a patient that comes in, normally doesn't take any medications, they're ready for surgery, or maybe they take some ibuprofen. There's a reminder that goes out 7 days early and says, please stop your ibuprofen and any anti-inflammatories. And then 3 days before, it says, hey, don't forget to do the special wash and the stuff in your nose to help prevent infection. And oh, by the way, have you gotten your house ready? And so that it'll fire off messages to you in a more timely manner, so that we have fewer cancellations and fewer drop balls on the patient side, our side, to make sure you get everything that you need. It sends out an outcome score. What is that? Well, it's a questionnaire that goes out to patients. It's a questionnaire that's based off of research questions, so that we know how we're doing. And that's something that's really exciting to me. When you go through a fellowship, you do a lot of research, and every patient that comes through fills out forms and checks boxes, like those old Scantrons that we had in my fellowship. And that all gets filed away so you can do studies on it, and you can prove that people are getting better. Well, we've not, in a private practice, even a big one now, you generally don't have a research staff. You don't have time to collect that data, but this technology will actually fire those questions out to you pre-op and at post-op, 1 week, 4 months, 1 year, whatever intervals we decide we need. And if you're so nice to actually fill those out, we can see how you did individually. And then we can also use it for us to see how we're doing better. And God forbid one surgeon has better outcomes than the others, we can start looking and drilling into why that might be. So this is not only a tool to help with communication with patients, but it also allows us to keep data, to keep ourselves honest and continue to improve. So again, we're taking all of our information, and we'll still give a book that will still have a class, but it breaks it down into little bits that are beneficial preoperatively, if nothing else, to shoot out to patients. And then postoperatively, as you can see here, what can you do and when? And here's some questions. And oh gosh, it's day 2. You're probably starting to feel that knee now. You had a good day, didn't you? How do you manage your pain? How do I get up and move? And when can I resume exercises and some of these things? And hey, don't forget your appointment coming up. By the way, how much pain are you having? And say, hey, is your incision looking clean, or does it have any redness? And you know what, if a patient says yes, it sends a note to us immediately. It triggers Amanda or Angela or someone to say, well, we got to get in touch with that person because you might have not given us a call at that time, or maybe we didn't return it, who knows? But if we don't have that contact, that communication, then we can miss things, and that can impact your care. So patient-centered care, when you sign up for a joint replacement at OrthoSC, we're going to take the information from our electronic record, and it's going to get dumped into this. So say Sally signs up for a total knee replacement. Here's Sally's medical record that's already in our system. It gets dumped automatically into this system. It allows us to start sending customized medications, reminders and things. You have, for instance, somebody taking Coumadin, which is a blood thinner, and they have to stop that at 7 days. Maybe you have somebody taking Eliquis, which is a different one, that's 3 days. It'll take that medication and tailor the messages to you. So we have fewer drop balls, fewer cancellations on your end, and ours as well. And it basically customizes this pathway to the parameters that we've put in based on evidence to take you along the path. And I mentioned there's different modes of communication with this. So there's the old-fashioned phone. There's the new phones, the so-called smartphones, texts, apps, email, website, different ways to log in, whatever suits your fancy. And you know what? If you don't want to participate, you don't have to. But I think it should be clear with this talk that I think it's a good thing for patients and a great way to potentially get you better outcomes. And what we found is that in this patient's, we haven't instituted yet, but what we expect to find, and what I know from colleagues that have used it, patients feel like they've had more contact with us, knowing that they've gotten these special reminders. And the ability to send a message quickly and securely, privacy technology, Or even if you don't intend to send a message, but you give us the wrong answer, something's not going the way we want to, you don't think it's a big deal, we're on top of that sooner than we had ever been. So here's an example of what the app might look like. It's got, here you are 9 days before surgery. Here's some reminders. We sent you these reminders by email. You want to look at them here. You want to open your email, however you want to do it. It's procedure specific, secure messaging. I mentioned the questionnaires. It even counts your steps. So if you look here, you can kind of see, hey, I did everything I need to do today. And let me look at that. So this was 9 days pre-op, and you've seen these things, and here's some more information. You got a couple more things you can check. You can get really involved with this or not. And one thing it can do, though, if you allow it to, and we'd prefer you did, is to even count your steps. So if you sign up for it early enough, we can see maybe you only took 3,000 steps before surgery, and now after surgery, you're actually doing 6,000. And maybe some patients say, I'm not doing any better. I say, well, listen, you doubled your step count. That's great. Let's count that for something. Or, hey, you think you're doing okay, but to be honest, you haven't been doing a whole lot. And typically I see people taking 6,000, you're only taking 3,000. Is that okay? Maybe it is for you. Maybe it's not. But we get the outcome scores. And you can see for this particular patient 4 weeks ago, prior to surgery, you only had a score of 20, and higher numbers are better. 2 weeks ago, you were making progress, and now you're even better. So you can look at this for yourself individually. And then again, as you aggregate this across, gosh, we do probably 2,000 or 2,500 joint replacements a year in our practice now between all the physicians. We can aggregate that pretty quickly and get some meaningful information. This is the other thing that goes on behind the scenes that you wouldn't see as a patient, but on our end of things, our nurses, our MA staff, coordinators, we know who's where in the process, and these are fake names, so this isn't a privacy thing, don't worry. But we've got people, and so these are different pathways. Ours would all say under pathway, total knee pathway, total hip pathway, total shoulder pathway type stuff. We have the patient, their medical record number, what they've done, what they haven't done, where they are in the process, and what alerts there are. And if somebody has an issue, it'll pop over to the left side of the screen and say there's an urgent issue for the nurse to click on, and the nurse knows that, hey, I need to call this person before I review the rest of this stuff. There's never been any technology like this to help us track patients, and it's never been more needed now that we're doing faster home discharges, particularly outside. And then as we get into it, and we haven't built this part of it yet, but even we'll build a potential database where if patients consent, we could build a database even of our implants to know that if there's ever an issue, we can contact patients, or we figure out that one's doing better than the other. So there's some sides of that that are really exciting as well. But again, bringing it back to the center of this, which is the patient, that's what we're here for, is to get people back on their feet. We want to develop, and we have developed, consistent pathways that will continue to modify and improve. We need to have better communication, particularly with less face-to-face time, more oversight, objective data that can help us do better. And so that quality feedback loop should allow us to do better and better as we go forward. A little blurb on the CareSense, and I don't have any stake in CareSense whatsoever. You should have a little background of the company that we're using on this. They're based out of Philadelphia. I know Charlie Giamatti quite well. His father's an orthopedic surgeon, and he was going into technology, and so he kind of married those two things together and built this years ago. They have started to use this extensively by many other practices and systems. J&J has tied it in with them to some degree. It's been implemented at over 250 hospitals, and now millions of patient surveys. And you look at Mass General, Houston Methodist. I mean, there's some big players that have used their technology here. Some of the bigger orthopedic names, OrthoIndy and probably ProLiance, may be the biggest, if I'm not mistaken, maybe one of the biggest orthopedic groups in the country. I think they're, if I'm not mistaken, out in Seattle, and I want to say they have 200 something orthopedic surgeons throughout the entire state of Washington. So this is a tried and true type technology that should work pretty well. And the results they've seen to this point in total joints is that they've actually been able to reduce their readmissions despite a declining length of stay, which is the next one. That stands for total joint replacement length of stay. They reduce it from 1.9 to 1.4 days. Now, that's not, but a half a day is a half a day. And that's an average of all comers. And despite reducing a length of stay, they also cut in half their readmissions. So a patient's having pain, instead of driving to the ER, they've clicked a number that's, say they have a pain 7 out of 10, they wouldn't have called us for it. That may generate a call for us. Hey, what's going on? So it may generate calls. It may reduce some calls. It's increased some hospital outcome scores. That's what HCAHPS are. And it has over 90%, 95% patient satisfaction. So just a little testimonial here, and this isn't me, and I couldn't tell you who the surgeon was. But, you know, again, I'll go ahead and read it. My patient this morning was so happy. He said he was so ready and confident to have his surgery because of the preoperative information. Methodist contacted him so much and sent him so much information. He was so ready. He said, I loved it. We hear this all the time now. I didn't tell him this was the first time in 20 years that one of my patients ever said these things. His joy is because of CareSense. Now, I'd argue that we've hopefully built our program, and I'd say that I do get these comments, and I have prior to CareSense, but I expect even more of them now with this technology. But then on the patient side, you know, some people don't like all the communication, but many do. Helps a lot. You're not lost. There's reminders. You can always go back to information that came to you before. It's parceled out where it's pretty easy. So I want to hear as much detail as the process, and this is awesome. So that's why we're doing this, is to take a process that can be a challenge and turn it into not just one that's successful long-term, because again, that marches on technology-wise, but turn it into hopefully an awesome process. And I think hips are kind of there. I can't tell you how many times now with total hips, especially anterior approach, surgery center, I've had literally, I could tell you the name if I was allowed to, a patient, 47-year-old, did a few years ago, who said, legitimately, this is my 26th surgery on my entire body, first one on the hip. And this is the easiest surgery, the best process I've ever had. And he was one of the first we did in the surgery center. So it's quite exciting to hear things like that. And I think as knee techniques and technology continue to improve, hopefully we can get there as well. But if nothing else, we can make it an easier process and a better process from a communication standpoint. So that's why we're here. That's why we're doing it. It's better outcomes and better quality of life. So I appreciate your time. I'll wrap it up there and open it up for any questions. Lisa, I'm going to need your help on this. So let's see if there's a way to unmute everybody. Do I have to do that? Because if so, we're going to have to wait for a second. Hang on. Maybe I can see. You're probably all watching this, but I don't care. Maybe I'll stop sharing. Then you can probably just see my mug. And yeah, I don't know. Is there a chat? Wait, here's a chat. No. There's a chat button at the bottom if you have any questions. Fire away. Otherwise, I'm going to unmute people. So beware. There might be a button to raise your hand. That might be another. Oh, hang on. I'm going to unmute. Apparently, I have the ability to mute Lisa. Let's see. There we go.
You can hear me now, Dr. Ramsey.
Yeah, I can.
Okay. One of the first questions that you cannot see, but I can, when do we start this system? When do we put it into effect?
Yeah, that's a great question. We have our system built on our end, and we're waiting for it to interface with the electronic health record. So we're basically there. But as you might imagine, some of those EHRs are cumbersome, so the interface is being developed. We expect it within the next couple months to have this thing enrolled. I've been told by the end of the year at the latest. So what I can definitively say is we're closer today than we've ever been. Any other hands, questions? Oh, somebody, Shirley, said, just loaded the app, but it is not working. Not sure what to say about that, as I've certainly had my own challenges. So there's a Q&A box. If you have something, go ahead and type it in. If you raise your hand, then I may be able to answer your question. All right, I'm gonna start unmuting people, so time to talk. All right, we got some people unmuted. That's how Zoom goes. You can mute yourself if you like. Is it easy to get in to see me? It's as easy as making a phone call, or I'm fairly certain we might even, I know we have an ability to request an appointment online. So whatever your preference is, you can go to orthosc.org and request something electronically, and one of our folks will get back to you, or you can call us. And I'm going to assume that either in the information you got to log in or in any follow-up information, that phone number will be given to you. Is it easy to get in to see me? It kind of depends on what's going on. I was out for a week, and that can be a little bit tough, but keep calling. We do keep a waiting list. Sometimes it's a few weeks to get in to see me, but we'll do my best. And then if it's not me, I certainly have excellent and capable partners as well. So our job here is not to have too much pride, is to take care of patients. So I'd love to help you, but at the same time, if you have an urgent issue and for whatever reason I can't get you in, then by all means, you can see either one of my partners, or sometimes even if it's just to get a foot in the door, see one of our nurse practitioner PAs who often can assess and start a workup, potentially order an X-ray, MRI or something, so that by the time you see me, the information I need is all completed. And sometimes that's an even more efficient way to do it. Both surgery centers are up and running now. There's a question, are they both up and running? And particularly recently in the last several months, there's been some off and on with elective surgery. We would consider this to be elective because it's not life-threatening. It certainly can be quality of life-threatening. Each of the hospitals, each of the surgery centers were shut down for about 6 weeks. So anything that wasn't urgent, that then opened back up, and we've had a hospital or two kind of lock back down from time to time as the community levels, wax and wane. The surgery centers are definitely both up and running. And again, I think in an environment where we can control a smaller staff and effectively not have sick people around as much as we can control it, or at least as much as we know, it should reduce the potential for those places running into those issues as we go forward. Another question is, will you be able to contact a nurse directly if I'm having a problem? Yes, so the app will contact my surgeon, contact my nurse, and so it should be as easy as clicking on a button there. Even now with our current materials, you should have not just a general number, but a direct number to the back line for the nurse or assistant that's working with your surgeon. And so it should be as easy as that. But within the app or program itself, there is a button where you can say, please get me in touch with, or please call me ASAP. Any other questions? Yeah, so this is a more of a comment, it looks like. It says this new program looks like it might streamline things better, and that's exactly the point. I mean, I think that's my point here, is that from a long-term outcome standpoint, there are definitely technologies and techniques that, it seems like the money we're spending as a system to get better results is, we're spending more money and maybe getting less out of it than we did a couple of decades ago. It doesn't mean that we'll stop, and it doesn't mean that innovation will stop as we move forward. Quite the opposite. But we've gotten, shall I say, such good results that it's difficult to move that needle that much further to get that much better results, and that will continue. But the outcomes that we're talking about in this talk really is about the process and making it easier. Anesthesia, less pain, sure, but making this a more streamlined process. And I think some of that will naturally come from going through a surgery center. Again, we just have way more control, smaller environment, fewer moving parts, a lot less administration. It's certainly where joint replacement, I would say, is going, if not already is. And then this program, both from a joint replacement program standpoint and this technology program, CareSense, that's the whole point, is we're trying to streamline this process to make it better. So joint replacement has really become, it's been a target for Medicare because it costs a lot, but it's also a target for Medicare because they can capture data. It's so standard. We're doing 2 operations, hips and knees, or 3 operations, shoulders, or what have you, over and over again. And so it's a big target for better and for worse, I think, for Medicare. And we end up piloting these things. So our plan here is to roll this out for total joints to start, streamline it, learn from it, evolve and get better, and then expand it to other subspecialties within orthopedics. And probably the next one would be spine, but other sports, hand, foot, etc., as we learn more and load more into the process. So does it cost me as a patient to be part of this program? No, it's just what we're doing. It makes sense. The cost for us is relatively nominal relative to what we think we'll get to our patients. There's a debate, as I was just talking about, Medicare keeps cutting hip and knee replacements because they stay less and less in the hospital. So they're cutting surgeon reimbursement and things. And our argument to that is, listen, we're doing better. We're costing you as a system less. We're spending on programs, but it's all to get better for the patients. So that's an esoteric thing. And I'm not here to, whine about money as an orthopedic surgeon. I get that. But the short answer is no, it doesn't cost you anything. We continue to do what we can to make this a better process and a better outcome for everyone. Any other questions? I may have missed it when you're starting the program. I've been told by the end of the year, and hopefully before then, one of the biggest stumbling blocks is integrating it with our current electronic health system. So we could roll it out now, but it would not have quite as much of the functionality. I mentioned before that it'll take a patient's medications and help us tailor their messaging, preoperative, postoperative, to tailor a little bit to their medications. It's not going to be super granular because that would probably get unsafe. I wouldn't want to depend on technology too much for that. But there are some key forks in the pathway road that we would like to have integrated with our system. And so we're waiting on that, and we're waiting for a bunch of IT guys, and it's not on our end. So hopefully in the next couple months. And this isn't me trying to get more business or anything. I don't know that I would necessarily wait for this. If you want to, by all means, it's elective surgery. You wait as long as you want. You wait till next year for any reason or beyond. It's one more dimension in my opinion, of what's a good process and just making it better. All right. So I was told that's all the questions that we've received. By all means, happy to talk in person with any of you. We're doing, obviously, our standard office visits. All of our offices are open, and we're doing our part as much as we can to keep people safe. So masks, what have you, and come on in. We also are offering telehealth. It's a little easier for most insurance carriers to do that as a follow-up visit, but there are certain carriers that will allow us to do it for new patients. So if you're more interested in telehealth for convenience or safety, we may be able to accommodate that. And I just got another question: is it possible to watch this Zoom again? And I'm fairly certain, Lisa, that the answer is yes. It will be on our website. So look for it there in 1 week or so. All right, everybody. Well, thank you so much. I appreciate all your time. Happy to meet some of you at some point. And if nothing else, even if I don't, I hope this gives you an idea of what we're all about, because that's the other thing I take about it. We're committed to enhancing the physician-patient relationship. We've probably lost some of that in the last several years, not us as OrthoSC, but as my personal take, administrative reasons, insurance reasons. And one of the biggest reasons we decided to pull off this merger is to take that control back, so we have the ability, the resources to implement programs like this that should benefit patients. So thank you guys for your time. I appreciate it. I'll go ahead and end the presentation, and hope to see you sometime soon.